Finally, yeah. So basically, when you decide on accepting a patient with pre-existing extrahepatic malignancy that has existed before, treated before, or just been discovered during liver transplant evaluation, there are several factors that you have to consider, and they could be associated with organ failure. This is from the AST and ASTS consensus opinion that was published in 2021. So they were talking about all of solid organ transplantation and malignancies. So it depends on organ failure. That means whether it's going to be a life-saving transplant or is there an alternative like a left ventricular assist device for the heart or dialysis for the kidney. But for liver transplantation, there is no such alternative. So then, of course, patient factors, that means whether you will improve their quality of life or it will be life-saving for them, and whether they have any modifiable or non-modifiable cancer risk factors. And then factors associated with the cancer, which means that is there favorable response to previous treatment or known favorable response to simple excisional surgery? What's the natural history of that cancer? And if the treatment has been done, then the time elapsed since treatment, and so on. And then, of course, there are immunosuppression factors, which means does specific types of immunosuppression influence recurrence rates in that cancer? So, so these guys put forward these guidelines saying that for selected tumors like breast, renal cell cancer, thyroid, bladder, it's perfectly okay to transplant them even while there is early disease, that's T1, in some cases T2, as long as that is treated. And while the consensus does not really specify that treatment can be done simultaneously, but those doing living donor liver transplantation will know that simultaneous treatment of these cancers in the early stage works very well, both in terms of saving the patient's life from liver failure or whatever the indication for transplant is, and also treating the cancer. So specifically for breast cancer, if you have DCIS stage 1, there is no wait after treatment. If it is stage 2 and 3, then 1 to 2 years or 3 to 5 years is recommended. And of course, none of the advanced cancers with metastasis, one should consider a transplant. So we're talking about non-metastatic, locally, either early or advanced cancer. Now, colon, generally people have shied away from in transplanting them early. So if you have stage 1, then you're looking at 1 year interval between curative treatment and transplant. Stage 2, T3 stage, 2 years, and stage 3, that's T4, is 3 to 5 years, if at all. But you know, what's not dealt with here is if you have a colonoscopy done on the patient pre-operatively, pre-transplant for whatever reason, and you discover a polyp, which turns out to have a cancer, which is not invading the muscularis, then what do? You just excise the polyp and wait for a year? Possibly not. I would just go ahead with transplant. So there are some gray areas even in colorectal cancer. Now in rectal cancer, if you have stage 1, which has been resected, 1 year wait is recommended. In renal cell cancer, if you have T1A or T1B with Fuhrman grade 1 or 2, that's considered good prognosis, good biology, early cancer, so there is no wait needed as long as you've treated that cancer. But for higher Fuhrman grades, or T1B, T2, there is 1 to 2 to more than 2 years of wait recommended. In bladder cancer, again, low, intermediate risk, you wait up to 6 months, and there is 2 years wait for a high-risk cancer. For thyroid, which is T1, T2 cured, that means thyroidectomy is done, with or without lymph node dissection, then you can actually go ahead and do it in 6 months, is what the recommendation is. Now, for prostate and gynecologic cancers, for very low risk and low risk cancers, there is no wait recommended, and surveillance is acceptable. For high risk cancers, there are nomograms which tell you the probability of survival, and you use them, and then you make your informed clinical decision whether to go ahead with a life-saving transplant, considering how long these patients are going to live. And again, Prashant's concept of transplant benefit really comes into play here as well. Although the benefit is now to be counted over treatment for an extrahepatic malignancy rather than a non-transplant treatment of a cancer of the liver. And then gynecologic cancers, endometrial cancer, again, low risk, no wait at all. And intermediate risk, 2 to 3 years wait, and high risk, 3 to 5 years. And very high risk, you exclude. Now, what does EASL say? EASL says that the basic principles are that you obviously have to do a multidisciplinary team meeting. That's a given anyway for all cancers. You capture the tumor type, the histology, the exact stage, the known treatments, the response to treatments, the remission duration. So all these have to be factored in as per the cartoon I showed you in the first slide, all the factors that influence selection of these patients. So you consider all those in your MBT. And then you do a balanced projection of the liver transplant benefit versus recurrence risk, which is what I just said. And there are actually AI models developed on this that you put in all the factors and then you see what the expected survival is. And then you plan therapy if there's a recurrence post-transplant. So you have to do all that before selecting the patient and accepting the patient for a transplant. And of course, they do not recommend any transplant for active malignancies, which is understood. We would not transplant any patient with an active malignancy which is not already treated or simultaneously treated. So there is no specific weight for very low-grade cancers with negligible recurrence risk according to the EASL guidelines, like a superficial non-melanoma skin cancer, in situ breast cancer, superficial bladder cancer, similar to the ASTS and AST recommendations, and prostate cancer, Gleason less than 6, incidental renal tumor less than 1 centimeters. Now, they don't separate firm and grades of tumors, renal tumors. And they have advised to look at modeled cure probabilities after solid organ transplantation. And when lung and breast are compared to colorectal, testicular, and thyroid, basically the system should get more permissive for colorectal cancer, thyroid, and testicular cancer compared to lung and breast, because the probability of those cancers in an advanced stage recurring after transplant are higher. So what is our experience? We've transplanted 20 patients with extrahepatic malignancies out of a total of nearly 5,000. And of the breakup was hematological malignancies. There were 5, Langerhans cell histiocytosis 2, leukemia 1, multiple myeloma 1, Hodgkin's lymphoma 1. All of these were previously treated, at least a year or more prior to transplant. Renal cell cancer, we had 4 cases. 2 of them underwent simultaneous. So we did 15 simultaneous extrahepatic malignancy curative surgeries along with living donor liver transplants. 4 were for renal cell cancer, 2 radical nephrectomies and 2 partial nephrectomies. Obviously, the kidney specialists, our colleagues, did that. And then breast cancer, we did 4 surgeries, 3 wide local excision, 1 mastectomy. Thyroid cancer, total thyroidectomy, 5 cases. The last one was done last week. Endometrial cancer, 1. So this was a patient who had total abdominal hysterectomy and bilateral salpingo-oophorectomy along with the transplant. And then squamous cell cancer, wide local excision 1. So our protocol is you accept these patients if they are curable at or before transplantation or in complete remission. Simple rule. Not always practical to biopsy these patients, but you should biopsy the extrahepatic malignancy if possible. because then you can understand the grade and also consider tumor biology. We are especially getting into that now because we've had one renal cell carcinoma recur, although long term. So what are the outcomes? We lost one patient early, and one died 11 months later from a cardiac cause. One is alive with late RCC recurrence at 5 years, and 18 out of 20 are alive at a mean follow-up of 52 months. 90% of them are alive. So obviously, if these guys were denied a transplant, they would have all been dead at this time. So the conclusion is that strict selection and simultaneous curative surgery enables safe living donor liver transplantation in patients with prior or pre-transplant extrahepatic malignancy. What's the experience elsewhere? There are small case series, one by Desai et al. Over about 10 years ago. So they had 16 odd cases with lymphoma 4, breast 3, and one each of the others listed there. And then cancer recurrence was seen, one in melanoma, one in leiomyosarcoma. Leiomyosarcoma is a bad tumor to do a transplant in. I would not touch that patient. And then they said that you could achieve good outcomes with proper selection and good tumor biology, which is correct. And then another series of 14 where 9 were detected during evaluation and 5 were known before. And they all did surgeries prior to transplant. The oncologic surgeries were done prior to transplant, average about 70 days prior. And they had 100% 5-year survival. So again, they demonstrated feasibility of this approach with rigorous selection. And there is this small series of 3 cases of renal cell cancer who also had simultaneous nephrectomy and good results, but they also selected early tumors. So to summarize, a mere diagnosis of extrahepatic malignancy does not contraindicate liver transplantation, but advanced metastatic cancer is a contraindication. So according to ASTS guidelines, stage and cancer-specific waiting intervals have to be devised and followed. So early cancers of thyroid, breast, renal, that's kidneys, bladder, prostate, and uterus, no wait is needed. Later stages, if they are cured, would generally say 1 to 2 years or more remission periods before transplant. EASL says the same thing, cancer-specific, no-wait categories, plus they would do cure probability modeling. We and others have found excellent outcomes with strict selection on above guidelines, plus documented remission in cases they've been treated before, or curative simultaneous surgery in case they've been discovered during liver transplant evaluation. And one always needs to individualize by biology, kinetics, remission duration, plan the immunosuppression, plan the tumor surveillance, and also plan the post-recurrence therapy should they recur after transplantation. This presentation was prepared by AI and me together. Thank you.
Thank you, Dr. Soin. How do you deal patients who are decompensated cirrhosis being evaluated for transplant and then simultaneously you discover...
Sorry, I didn't get the first part.
Patients who have decompensated cirrhosis who are being evaluated for liver transplant.
Patients who have?
Decompensated cirrhosis.
Decompensated cirrhosis, yeah.
Who are being evaluated for transplant, and then you have a breast, thyroid, or endometrial or colonic malignancy. And these patients cannot be subjected to surgery, breast surgery or colonic surgery, and then you have, they can't even be given chemotherapy. So would you do in the same setting both transplant and...
So, I mean, obviously, if they have decompensated cirrhosis, they will not tolerate major surgery under general anesthesia. That's understood, which is why majority of our patients in this situation have had simultaneous curative surgeries. But if you're thinking colorectal, then I think you're in a difficult situation, especially if it's a big lesion, if it's a, established muscularis invasion or a T2 or a more lesion with nodes, then you're really in trouble. Then you can't really be treating. We would not like to do intestinal or colorectal surgery along with transplantation. But like I've shown you, we've done breast, thyroid, and kidneys and skin. So that can be done along with transplantation.
Sir, for how many colorectal malignancies did you manage? Sir?
We don't have any colorectal in our series, no.
No, nothing. No.
We have done 2 cases where we excised polyps. One later turned out to have cancer, but we didn't actually know that at the time of doing the transplant.
I think colonic tumors are different from rectal tumors. So colonic maybe we can do in a same setting, just a resection and anastomosis. But tumors which require anti-resection or low anti-resection probably should.
I don't know, I can't hear your question properly. There's some muffling of the...
I said colonic tumors are different from rectal tumors. Colonic tumors probably you can deal in the same setting, but rectal tumors which require anti-resection or low anti-resection, probably they should not be dealt with.
So you're saying colon and rectal tumors are different?
Colonic are different from rectal.
Colonic is more?
Are different from rectal.
Yes, of course they are different.
So colonic may be dealt with in the same setting along with transplant, but rectal tumors which require anti-resection or low anti-resection, they are different.
Yeah. So there is a difference, and I think that that's what I said in the guidelines. That's what the ASTS guidelines also say, that you generally have to wait a year after treating colonic cancer. And if you're in a situation where where the recipient is not going to live for that much time, then I think that's a decision that you have to make at that time. But I don't think it's worth saving someone's life to live a year, but it's certainly worth saving their life to live 3 to 5 years. But that's, it's not something that you and I can decide. You have to talk to the family and decide. But we haven't done any colorectal cases.
One question, sir. Suppose there is a young patient, relatively young patient, less than 40 years patient, decompensated CLT, and there is a simultaneous...
Compensated or decompensated?
Decompensated CLT. He needs transplant, obviously. And there is a simultaneous tumor like colon or renal. Simultaneous surgery is not possible, as you said, because especially colonic tumors. So is there any possibility to give a chance, do the transplant, don't touch the tumor? Once the patient comes out of, like after 2-3 weeks, is it possible? And theoretical question. Considering the age of the patient.
So yes, that is possible. We have discussed this option for kidney and thyroid cancers in the cases that we actually did along with the transplant. We've discussed these with the kidney surgeon and the thyroid surgeon, and they have also given that option that once you do the liver transplant, we can operate on them afterwards, 4 weeks, 6 weeks later. Colon, we've not really considered, I've told you this before. But I think that somehow we rationalize that because you give significant amount of immunosuppression in the first month, then you may already do some of the harm that is immunosuppression related by waiting for a month to treat these tumors. So with that logic, we've gone ahead simultaneously.
Dr. Soin, a really nice, thought-provoking talk.
Hi.
I had a question about the breast cancers, which you're doing concurrently with liver transplant. Say you do the sentinel node biopsy and you find like 3 nodes that are positive. Then do you still go ahead with the transplant, or what do you do then?
Well, I think that this hasn't happened to us, but if that were the case, then I guess they would have the lymph node dissection done at the same time and would still go ahead. Yeah.
I see. And then just post-op.
Yeah, I think if the a priori plan was to go ahead with simultaneous surgery, we would stick with the plan.
Okay. Thank you, Dr. Soin, and thanks for taking up this challenging talk, actually. I just wanted to say that I did a random survey of some of the units, and a lot of centers are doing this. Thyroids, kidneys, and we've done a colon. So, in fact, we're trying to do like a survey study across all the big centers in the country, because I'm sure it's happening, but it's not there out in the literature. And this is one area I think we need to look at and maybe create some guidelines on the line of what you suggested in your talk. Thank you.
It'll be interesting to actually put this data into our registry and see where we get.
Yeah.
Yeah.
Thank you.